everyone. First of all, let me thank Dr. Wonder for giving me an opportunity to speak to you on a disease which is quite prevalent in our country. And secondly, I will compliment him for whisking away the whole topic and hammering it so well that last night I had to make effort to see that the slides are totally different from what he projected, because he did diabetes and heart disease in India. The first point I'd like to make is that the prevalence of diabetes is increasing world over. And the result is that the mortality, which is about 1.8 times, and the cardiovascular mortality, which is 1.676 times from the ordinary population, is much higher. So let's see what happens in India. As you can see, both the Indian as well as the urban as well as the rural, there is a marked increase in the incidence of coronary artery disease in diabetic population, and it is progressively and gradually increasing over a period of time. To just sum up what he had said yesterday, it's one of the important non-communicable diseases in India and which tops the list. They are not only seen in the affluent NRIs, which was previously thought, but I think the similar population transition which is taking place in India has led to the occurrence of this dual epidemic, both from rural to the urban areas in the country. And it is also spreading to the lower and middle income group because their lifestyle is also changing. And the risk of coronary artery disease in a diabetic population is 2 to 4 times higher. And the most important point is that it occurs 1 to 2 decades earlier than the West. So our most productive years are lost. Diabetes doubles the risk of vascular events. What does it do? It involves both the microvascular as well as the macrovascular complications, and pertaining especially to the heart, it can lead on to the coronary artery disease, a cardiomyopathy, and the occurrence of congestive heart failure. On this, I would like a little time to tell you that the concept that diabetes is a cardiovascular risk equivalent, which was propounded by Steve Hafner and from some studies in Finland, has now been challenged, and in a beautiful article written by Sattar in Diabetologia in 2013, he suggested that that's not true. So if you see the diabetic population gradually growing over a period of time, a person who has at the age of 30, a person who gets diabetes at the age of 30 or 35 does not have the same amount of risk as a person who develops diabetes at 55 or 60 years, and the duration of diabetes is 8 to 10 years. Similarly, as Professor Senani was trying to tell you, that the association of metabolic syndrome and the occurrence of the age at which it comes up, the increase in the body weight, and both the phenotype of the individual. And now we are looking at the loci in genetics which increase the risk. So therefore, diabetes is a heterogeneous disease. So every diabetic cannot be said to be having cardiovascular risk equivalent. So what is the importance of glucose? Whether you look at the fasting blood glucose or you look at the postprandial glucose, though it is little more with postprandial glucose, that there is an increase in the cardiovascular risk. Well, if you look at the HbA1c, you can see with the progressive rise in the HbA1c, there is an increase in the cardiovascular events. The point I like to make here is that if you see less than 5 and between 5 and 5.4, the risk practically doubles and continues to increase exponentially. Whether the treatment will really help or not is a question mark which is not still answered. And one of the things which really bothered people was that in the initial phase of both UKPDS and the DCCT, the cardiovascular risk reduction did not happen to that extent. And then came the so-called the Accord, VADT, and advanced trial. Now, in these three trials, the first trial, the Accord trial, created a scare and a flutter. There was a lot of debate because there was increase in the mortality. So if you treat somebody and he dies earlier and much more, then I think it is really scary. But when they tried to look at the meta-analysis of all these trials put together, then it was found that they are cardiac neutral. In UKPDS trial, over a long period of time, it was seen that whatever treatment we gave, there was a little difference in the mortality, especially with the metformin group. This made people to rethink, and the rethinking concluded that probably the UKPDS trial was given to people at the very beginning of diabetes as compared to the recent three trials where the treatment was given where diabetes was established, where there were associated cardiovascular risk factors, or the person had already suffered a cardiovascular event. So then I think we have to look for the so-called metabolic memory. As you can see that gradually when you take the duration increases, the morbidity and mortality tries to go up. But if you try and reduce the sugar very fast at that point of time, there's going to be no difference. And this was further contributed by the fact that in Accord trial, even when the patient blood pressure and lipid lowering was done, the results did not change and the cardiovascular morbidity and mortality did not change. People said that why not look at the lifestyle modification? We are hammering day in and day out, lifestyle modification is very important. In Look-Ahead trial, which had to be stopped earlier just for this reason, that lifestyle also in later part of diabetes does not make any difference. So ladies and gentlemen, the question today is, and we got to seriously think whether at what level and how quickly we should try and act in diabetic patients so that the macrovascular, especially the cardiovascular disease, is reduced. Is insulin atherogenic? Is hyperinsulinemia the only marker of insulin resistance? And you all very well know with the parameters of metabolic syndrome, again a controversial subject, where across the Atlantic, UK people believed that metabolic syndrome is a really entity, while USA started having doubts about the entity of metabolic syndrome. If you consider insulin resistance, you find that all risk factors pertaining to cardiovascular disease increase, that is hypertension, hyperglycemia, dyslipidemia, and especially the phenotype in our country, the genetics, sedentary lifestyle, obesity, aging, all these, and most important is there is activation of the cytokinins as well as the infective as well as inflammatory markers. Whatever we may believe in, whether we believe there is a metabolic syndrome or not, and whatever constellation you want to put, because there are multiple definitions, in all you see the result is one. There is increase in the cardiovascular abnormalities as well as increase in the mortality. Let's look at the phenotype in Indians, where we find there is abdominal fat scattered all over. Because of this fat, adipose tissue, which is wrapping around us, whether it is in the heart, whether it is at the level of muscle, or in the liver, or the abdominal fat, which we consider as serious, is responsible for increase in the morbidity and mortality, because as you all very well know that the abdominal fat is one of the most important and the biggest endocrine system in the body. And you can very well see what we said, that it tends to increase all those factors which contribute to the occurrence of thrombosis as well as the setting up of the atherogenesis and atherosclerosis in the vascular wall. If you look at the various parameters which are measurable, fibrinogen, CRP, plasma activation in time PA1, all seem to be more in patients of diabetes mellitus. So how I can prevent it? I think this slide says all, and this is the most important factor which we are talking about today. To sum it up, low-fat diet, weight loss, aspirin therapy. Now here there is a rider, and that rider is that aspirin therapy in those doses of 75 milligram to 150 milligram have not to be used. We have to give, to silence the inflammatory process, high doses of aspirin. Statin therapy, insulin and insulin sensitizer may be used. This sums up the number of medications which are required in trying to control the diabetes and tend to see whether they have any cardiovascular effects or not. This is a repetition of the slide which I said earlier, that even lifestyle measures, various trials at the moment have not shown any difference in the morbidity and mortality, and the question mark is when to intervene and how to intervene. Let's look at the three major trials for microvascular disease. The result is unequivocal, that if you tend to reduce it by 7 or little less than 7 without causing much of hypoglycemia, the results are good. But for macrovascular disease, the results are doubtful. As compared to the reduction in glucose level, you can see that a 4 millimeter reduction in blood pressure. Again, this is the study from Satar, where it was found more than 12 deaths are prevented. 1 millimole reduction in LDL-C does it in approximately 8% of people, while the result is very low when you reduce the sugar levels. Let's look at the insulin sensitizer. We thought there is insulin resistance, so there is a chance that if you use insulin sensitizer, the result may be much beneficial. But compared to the placebo, the results were not very good. If you look at, can I just ask a question? How many of us think that insulin is atherogenic and metformin prevents heart disease? Can you? Second part is correct, you think. So all our diabetologist friends think, can I ask you, sir, in this world of evidence-based medicine, based on 300 cases shown only in one trial, that is the UKPDS trial, we believe that metformin is cardiac safe. Well, that's not true. If you look at both insulin and metformin in the origin trial, the results speak for themselves, that our thinking is a myth. GLP-1 analogs, the newer drugs which has come, I think the reduction in weight results in reduction of all the other risk factors which may prove to be beneficial. If you look at the DPP-4 inhibitors, I think there is another if and but, that is in the Indian context. The two studies appearing from our country, one by Mohan's group and the other one by Dr. Shashank Joshi, they show that the DPP-4 inhibitors in our country show a little more reduction in HbA1c levels. Now let's look at these various trials. The sum and substance of all these trials is that DPP-4 inhibitors are cardiac neutral. So that means there is one satisfaction, we are doing no harm. Out of this, the severe trial showed that in case of this one particular gliptin, there is an increase in the rate of congestive heart failure and admissions, while rest of the trials were neutral. In this situation, a trial pertaining to a new group of drugs came, and that was the SLG2 inhibitors, and that is the EMPA-REG trial, which has created commotion in last 1 year, and it is likely that it will cause a change in the way the guidelines are going to be preached in the subsequent years, and you can see both the cardiovascular death and all-cause mortality are reduced, and this is the percentages put in words. Now in these trials, we are usually not comparing head-to-head basis, and therefore it was a pleasant surprise in the Carolina trial. In the initial phase, it has been found out that linagliptin, when it is compared to sulfonylureas, shows a twice the level of benefit. Now the question is it the sulfonylurea which is bad or linagliptin really good? I am afraid whatever literature I looked at, the answers were not there, that which is a better drug. The next important point, and an important trial which will answer quite a bit of our question, and a very sweeping statement which I made, that we need to use higher doses of salicylates so that it can be reduced, is maybe comes from this trial where we are trying to do the cardiovascular studies by NCTT. So in summary, it is a significant cause of morbidity and mortality globally, and is leading cause of death in people with type 2 diabetes. Type 2 diabetes is a major independent risk factor for cardiovascular disease, endothelial dysfunction. Atherosclerosis is accelerated in patients with type 2 diabetes. Visceral adiposity and the places where fat is distributed, especially in particular areas, causes inflammation and atherogenic dyslipidemia. Obesity and diabetes have to be treated well. Traditional risk factors do not fully explain the risk, and non-traditional risk factors will have to be considered. Obesity-related inflammation has to maybe the common soil for cardiovascular and diabetes. Sensitizers improve the risk factors but fail to reduce cardiovascular events. We wait the results from the newer trials which are still continuing, and maybe we have a little better future.